I have no conflicts of interest to declare, and this program has received financial support from the Ontario Ministry of Health and Long-Term Care. Our learning objectives today is to identify College of Physicians and Surgeons of Ontario and Ontario College of Pharmacists policies that pharmacists refer to when dispensing methadone in Ontario. We're going to review the current OCP opioid policy, formerly known as the Methadone Maintenance Treatment and Dispensing Policy. We're going to review the labeling, documentation, and staff training requirements for dispensing methadone. We're going to list the required and additional references as well as resources for dispensing methadone. And we're going to briefly review buprenorphine naloxone dispensing, including the list of references and resources. If we look at the statistics for methadone in Ontario, we can see that the number of physicians has remained steady since April 2017 at approximately 500, and the number of pharmacies shows a slight increase. Now, the 1,759 pharmacies statistically that dispense methadone in Ontario would include those that dispense methadone for pain as well. Opioid agonist maintenance treatment involves the prescribing of buprenorphine naloxone or methadone as part of a comprehensive program which includes counseling to help the person in treatment reduce or stop the harmful use of opioids. Methadone is the most studied and longest used pharmacological treatment for opioid dependence. Buprenorphine is another commonly prescribed treatment option. A third option, slow-release morphine, may be used as OAMT in individuals who have not benefited from treatment with methadone or buprenorphine naloxone. In Canada, this use is considered off-label and requires careful review of risks and benefits, fully informed consent of the patient, and rigorous clinical documentation. A third option, slow-release morphine, may be used as OAMT in individuals who have not benefited from treatment with methadone or buprenorphine naloxone. In Canada, this use is considered off-label and requires careful review of risks and benefits, fully informed consent of the patient, and rigorous clinical documentation. If we look at the Ontario College of Pharmacists opioid policy, it was revised in December 2018, formerly known as the OMT and Dispensing Policy. OCP instituted an opioid strategy to address opioid-related issues relevant to pharmacy practice in alignment with the college's mandate to serve and protect the public. The college's opioid strategy focuses on advancing opioid-related education, harm reduction initiatives, strategies to prevent opioid use disorder, and promoting quality assurance specific to opioid security and dispensing. And we provided a link to this policy. The purpose and scope of this policy outlines the college's expectations for pharmacy professionals regarding opioids. The purpose of this policy is to promote safe and appropriate opioid use through education and training, sharing of evidence-based best practice, and outlining expectations. This policy provides further direction to pharmacists regarding the NAPRA model, standards of practice, and is applicable to any opioid therapy, regardless of the indication or practice setting. The opioid policy was developed to support the college's mandate to serve and protect the public interest and is grounded in the following principles. Pharmacy professionals should employ the same respectful, patient-centered, professional approaches and attitudes towards all patients receiving opioid therapy, regardless of indication. Pharmacy practice should be in alignment with the federal and provincial strategies and Health Quality Ontario quality standards with respect to opioids. Pharmacists should abide by the most recent clinical practice guidelines and the appropriate standards of practice to ensure best patient outcomes for individuals on opioid therapy. Pharmacists play an important role in ensuring appropriate access to controlled substances. Pharmacists must abide by specific requirements when providing opioid agonist treatment. Now we'll look at the education and training. Although pharmacists must be confident that they have sufficient clinical knowledge, relevant training, and skills with regard to any medications, special considerations need to be made for opioid therapy. Pharmacists should have knowledge of the best evidence and relevant clinical practice guidelines specific to opioid therapy. Pharmacists should ensure they review opioid-related educational material, including tools on the OCP website, to ensure they provide optimal care to all patients on opioid therapy. If we look at opioid agonist treatment, buprenorphine, naloxone, and methadone play an important role in the treatment of opioid use disorder because they are opioid agonists which cause little to no euphoria. A pharmacist should have the necessary knowledge and training to provide opioid agonist treatment. Pharmacists should practice in accordance with CAMH's Opioid Agonist Maintenance Treatment, a pharmacist's guide to methadone and buprenorphine for opioid use disorder. And we've provided a link to purchase the text. Pharmacists dispensing methadone should be in compliance with the fact sheet, key requirements for methadone dispensing as outlined by the college, and we provided a We look at record keeping. Robust record keeping and documentation processes should be in place to support accuracy of information for administered doses to ensure safety at all times, especially during transitions of care. In other words, when a patient is entering or being discharged from hospital, from a jail or correctional institution, and restricted guest dosing. If we look at patient agreements, a written agreement serves as best practice to outline expectations and prevent miscommunication. A sample maintenance agreement template can be found in Opioid Agonist Maintenance Treatment by CAMH, the current 3rd edition. This agreement may include expectations of all parties, such as the hours of operation, consequences of inappropriate behavior, the patient's consent to access and share personal health info with other health professionals, a notice to the patient that doses will be withheld if patient appears intoxicated or under the influence of substances, and a notice to patient that missed, lost, stolen, or wasted doses will not be replaced without a prescription. As regards the sample patient agreement, I recommend that you do your own agreement and use this strictly as a template. Note, if there are significant changes in your pharmacy's policies, such as hours of operation, use of lock boxes, then you should revise the agreement and have your patient re-sign. We're going to briefly look at transfer of custody. If pharmacists transfer custody of individually labeled doses of methadone to a physician or his or her delegate for administration, policies and procedures should be in place to ensure documentation of receipt, administration, and daily reconciliation of doses. In this case, a delegate is a currently licensed registered nurse, registered practical nurse, registered nurse extended class, or healthcare professional regulated under the Regulated Health Professions Act, who have demonstrated to the satisfaction of the physician an understanding of MMT, including the risks associated with it. Pharmacists must either directly hand the doses of methadone to the physician or his or her delegate, or use a method of transportation that ensures they are aware of and can track who has had custody of the drug at any given time to ensure safekeeping of the methadone while in transfer. This would include a chain of signatures and the use of tamper-proof boxes. All methadone must be transported in an accountable and secure manner as described above, and in such a manner as to avoid extremes in temperature or delays in transport which could compromise the drug. Pharmacists dispensing buprenorphine, naloxone, and methadone should be familiar with the principle and guidelines outlined in CAMH's Opioid Agonist Maintenance Treatment, a pharmacist's guide to methadone and buprenorphine for opioid use disorder. CAMH provides mandatory initial training for pharmacists. This training must be completed by the designated manager within the first 6 months of beginning a methadone practice. And in addition, at least one staff pharmacist must complete this training within 1 year. Ideally, all pharmacists providing buprenorphine, naloxone, and methadone services should have knowledge of the best evidence and relevant clinical practice guidelines. It is the designated manager's responsibility to inform all pharmacists working in a pharmacy, including relief pharmacists, if that pharmacy provides opioid agonist treatment. 2 options for education through CAMH. Option 1 is the Opioid Dependence Treatment Core course, and we've provided the link. It's intended for physicians, pharmacists, nurses, counselors, and other healthcare professionals. It requires the completion of 5 online modules, plus attendance at a 1-day weekend workshop, and the cost is approximately $450. Note, the register as soon as possible was classes fill up very quickly. And in a class of about 50 people, there was only 30 spots for pharmacists.
Option 2 is an online self-learning program with no face-to-face component, available through CAMH. There are 6 online modules to be completed. As well, you need to submit 2 case studies and an interprofessional reflection paper. The OPA Methadone Education Program does not satisfy the initial training requirements. However, it is acceptable as a training update, which is required every 5 years by OCP. You need to complete 5 online modules, including this module entitled Policies Guiding Methadone Dispensing in Ontario. Or you can complete the OPA Live 1-day Methadone, Buprenorphine, and the Community Program.
OPA online modules and live program designed to provide all pharmacists with tools to effectively manage their patients on MMT, and it's available free to all pharmacists as an education update at any time. Complimentary sessions are provided with funding from the Ministry of Health and Long-Term Care. We look at methadone dispensing requirements. The pharmacist receives a written or fax prescription from a prescriber and prepares a dose of methadone. Doses are prepared according to CAMH, Opioid Agonist Maintenance Treatment, the prescriber's instructions, standards of practice, the Drugs and Pharmacies Regulations Act, and the Narcotic Control Regulation. Preparation of the final dosage form. Pharmacist prepares individually labeled doses of methadone using a manufactured product, which is a 10 milligram per ml solution, diluted in at least 100 ml of a vehicle that does not lend itself to injection. In this case, mostly orange-flavored Tang. Please note, graduated cylinders are not suitable for accurate dose measurement. Methadone solution for take-home doses of carriers must be dispensed with child-proof safety caps. In this case, there is no opting out and there is no signing of a waiver. Labels on all dispensed methadone must be in accordance with the DPRA Section 156. And in addition, the label on each dose must include drink entire contents of bottle, the date of ingestion for take-home doses or carries, a keep refrigerated auxiliary label for take-home doses or carries, or the keep refrigerated could be typed as part of the directions. The total dose in milligrams of methadone contained in the bottle, either 5 milligrams of methadone or the number of mils of methadone, 10 milligram per mil. The current solution available is Methadose. We're going to look at 2 examples of an acceptable prescription label. As you can see in the first example, the contents are written in milligrams of methadone in orange drink, and the drug file contains 50 milligrams of methadone.
This is an example of an acceptable prescription label. In this case, the prescription label shows the drug file as a number of milligrams of methadone, MAL being the manufacturer of Methadose. And you'll notice on the second line after the drink entire contents of bottle, the pharmacist has typed in methadone 50 milligrams in orange drink, just to reinforce the dose for the patient.
In the second example, we're going to look at, you can notice that the drink entire retake. In the second example we're going to look at, you can see that methadone 50 milligrams in orange drink is typed as part of the directions, but in the case of the drug file, is written as a number of mils of methadone and 10 milligram per mil, which 5 times 10 is the 50 milligrams. One of the following auxiliary labels must be used when dispensing. Methadone may cause serious harm to someone other than the intended patient, not to be used by anyone other than the patient for whom it was intended, and it may be fatal to child or adult. Or you can use the label methadone may cause serious harm to someone other than the intended patient, may be fatal to child or adult. It's important to note that these labels must be typed exactly word for word, and there cannot be shortening or abbreviations used. Administering the methadone dose. Ideally, you would select a private or confidential area. Only the pharmacist is able to assess whether the patient appears to be intoxicated or under the influence of other substances. And only the pharmacist has the training to ensure it is safe for the patient to ingest methadone, as well as to ensure the entire dose is swallowed to minimize diversion. You need to positively identify the patient, often in the use of photo ID, and confirm the dose with the patient. In other words, ask what the patient's is, not to confirm, is this your dose? After the daily dose of methadone is prepared, the pharmacist must do one of the following: observe the patient ingest dose in the pharmacy and provides authorized carries to the patient. Or the pharmacist can take the dose to patients at a treatment location and observe ingestion of the first dose and provide carries at the treatment location. With respect to documentation, observation is documented daily in the patient record so that it can determine where each dose of methadone went. This should include the patient's name, dose, date, and time, and if needed, the place where dose was observed in the case of transfer of custody. When a physician or delegate administers the methadone, the dispensing pharmacist must be provided with copies of these records daily. All documentation must provide an audit trail and be readily retrievable. Unused doses of methadone remain in the pharmacy and are destroyed according to OCP policy, standards of practice, and applicable laws, or, in the case of transfer of custody, returned to the pharmacy by the physician or his or her delegate, preferably on a daily basis, signed for upon receipt, entered in the appropriate record, and destroyed according to OCP policy, standards of practice, and applicable laws.
Methadone dispensing daily reconciliation pertaining to transfer of custody. A daily reconciliation of the methadone dispensed to and received from a treatment location is conducted in such a manner that would allow for immediate detection of any losses or diverted quantities. In this case, the number of doses sent to the treatment location must equal the number of doses dispensed plus any doses that are returned to the pharmacy. You should maintain patient confidentiality and privacy when you're administering methadone. It should be done in an and manner which ensures patient confidentiality and privacy.
We're going to look at the exceptional dispensing of a compounded product. If you're preparing a compounded product of methadone, you must follow the NAPRA model standards for pharmacy compounding of non-sterile preparations. It's only permitted in the following cases: therapeutic need. A patient is unable to tolerate the commercially manufactured product. What this means is that there's an actual allergy in the case of maybe an allergy to one of the preservatives in the commercial product. It does not mean that they don't like the taste or they don't think it doesn't work as well. ODB requires the physician to submit a request to the Exceptional Access Program along with a completed adverse drug reaction form. It's also permitted in the lack of product availability, and also in the case where a concentration less than the commercially manufactured 10 milligram per ml solution is required. In the case of institutions, as here we're talking about long-term care, correctional institutions, hospitals, etc., this is not considered to be transfer of custody. We treat it similarly to a narcotic delivery. It must be auditable and traceable. The institutions should have established written policies on secure handling and administration of the methadone dose. Reporting to OCP, the owner or designated manager must send methadone dispensing notification form to OCP within 7 days of beginning to dispense methadone, and we provided a link to the document. This information is communicated to the OCP practice advisors, formerly called inspectors. The methadone dispensing notification form contains pharmacy information, the start and stop date of methadone dispensing, the hours of operation, a description of the methadone services provided. Is it MMT? Are you accepting new patients? And are you participating in transfer of custody? Methadone training declaration identifies the designated manager and pharmacist plus the dates of the required course. Note, any changes in status must be communicated to OCP by submitting an updated reporting to the college form. We're going to briefly look at methadone for pain management. There's no formal training required for pharmacists. However, you need to be aware of the requirements regarding methadone for pain. You need to submit a methadone dispensing reporting form to OCP, and you need to also be familiar with CPSO policies and guidelines. The required reference is the MMT Program Standards and Clinical Guidelines from CPSO 2011 for chronic non-cancer pain, and we've provided a link. Also, you should refer to the 2017 Canadian Guideline for Opioids for chronic non-cancer pain. If we look briefly at CPSO MMT Program Standards and Clinical Guidelines from February 2011, MT physician requirements are a certificate of registration in Ontario, a member in good standing with CPSO, complete a statement of intent document, complete the opioid dependence treatment core course through CAMH, complete 1 day of clinical training with an MMT physician approved by CPSO, or successfully complete the CAMH 1 day simulation prescriber program. As regards methadone for pain management, physicians who wish to prescribe methadone for analgesia are expected to be knowledgeable about CPO's prescribing drugs policies, be familiar with current guidelines for prescribing methadone for analgesia, and demonstrate the requisite knowledge, skills, and judgment required to prescribe this medication. Effective May 19, 2018, physicians are no longer required to hold an exemption from Health Canada, the Controlled Drug and Substances Act, in order to prescribe methadone for pain and/or addiction. Since May 29, 2018, nurse practitioners who have completed college-approved controlled substances education can prescribe opioids and controlled substances, which does include methadone, and we provide a link to their policy. If we briefly look at the MMT policy for opioid dependence for May 2010, this policy articulates the CPSO's expectations of physicians who provide methadone maintenance treatment, including expectations for delegating the authority for methadone administration to other properly qualified healthcare professionals, and we've provided a link to the policy. Physicians may apply to CPSO for a delegation exemption. This is different than the previous Health Canada delegation exemption. This delegation exemption grants permission to delegate authority for the administration component of MMT to other properly qualified healthcare professionals. It's intended to improve access to care. Delegates must possess the appropriate knowledge, skill, and judgment needed to safely administer methadone to patients, and the pharmacist is responsible for the safety and integrity of methadone until such time as he or she has transferred custody of the methadone to an exempted physician or his or her delegate. Delegates are currently licensed registered nurse, registered practical nurse, or registered nurse extended class who have demonstrated to the satisfaction of physician an understanding of MMT, including the risks associated with it, or it could be another healthcare professional regulated under the Regulated Health Professions Act who have completed the methadone treatment workshop at CAMH or equivalent training approved by CPSO, and demonstrates the understanding of MMT, including the risks associated with it. We look at the required references. Each pharmacy needs to purchase CAMH Opioid Agonist Maintenance Treatment, the 3rd edition, only available in print form. You need to have a printed version or a link to CPSO Methadone Maintenance Treatment Program Standards and Clinical Guidelines, 4th edition from 2011, and we provided a link for that. And you need to have a copy or a link to the CPSO Methadone Maintenance Treatment for Opioid Dependence Policy Statement number 2-10. If we look at additional references, OCP has methadone practice tools available on their website, and we provided the link. And OCP also has a fact sheet, key requirements in methadone dispensing, and the link is provided. If we look at resources, OPA has an opioid substitution therapies drug info line, which is free to all pharmacists, available from Monday to Friday, 9 to 5, at the following phone number. The Ontario Pharmacists Association Methadone and Buprenorphine Toolkits for Pharmacists are free to all pharmacists and available online and for download, and the link is provided. We look at additional resources. CPSO also provides methadone news, which is free to all pharmacists. Just email a request to CPSO, and it's available online. CPSO also has a methadone information line at extension 661, and this is service for physicians prescribing methadone and a referral service for patients who are looking for a methadone or Suboxone clinic in their area. CAMH also has addiction clinical consultation service available Monday to Friday at 8 to 4 at the following phone numbers. And Opioid has opioid substitution therapies at discussion forum, which is free to join for all pharmacists. We briefly look at buprenorphine. Health Canada does not place the same restrictions on buprenorphine as methadone, and there is no current policies from OCP or CPSO. Pharmacists that dispense buprenorphine are expected to be familiar with the drug, side effects, administration, and treatment guidelines. And information is now included along with methadone in the text CAM8 Opioid Agonist Maintenance Treatment, 3rd edition. If we look at buprenorphine resources, OCP provides an article, Buprenorphine for the Treatment of Opioid Dependence, available from their library or for download. Suboxone also has an education program, and the link is provided. CAMH, buprenorphine naloxone for opioid dependence clinical practice guidelines. It's a PowerPoint presentation.